Everyone, welcome. It's going to be recorded. As always, just wanted to open up rounds with a couple of quick announcements about upcoming activities. So next week, December 20th, is our final rounds before the holiday. And we'll have Doctors Madeline Ferracuti, Nadine Najati, Lara Hazelton, and Jason Morrison. And it's going to be our annual You Should Read This. So hopefully people have submitted lots of ideas to them, and hopefully people can join us. Then we will have our break over the holidays, and we'll start back on January the 3rd with Dr. Katie Lines. I don't have her title yet, but stay tuned and it will be posted. It will be posted on the website if people are interested. This morning, I am so pleased to welcome our University Rounds speaker, Dr. Bernadette Grosjean. Dr. Grosjean sees herself fundamentally as a clinician and an educator. She's worked as a psychiatrist in Belgium, then California for over 30 years, in private practice, community hospitals, and in the field, and particularly in Los Angeles with the homeless population. She was associate professor of psychiatry at UCLA between 2005 and 2016. And since 2003, she's been working with a nonprofit in Los Angeles, working mostly with undocumented immigrants, victims of torture and trauma. She cares very much for patients who are too often neglected, misunderstood, or ostracized. She has a lifelong interest in working with patients with borderline personality disorders, and for the last 10 years has focused her work with autistic adults without intellectual disability. She co-authored Le Manuel de Borderline in 2014, Le Manuel du Bipolaire in 2017, and Le Manuel d'Autiste in 2022, the first comprehensive guides in French about BPD, bipolar disorders, and adult autism for patients, their families, and their providers. She's given numerous lectures nationally and internationally. And I just want to extend a very warm welcome to you this morning, Dr. Grosjean. If people aren't thinking about this, she is joining us from California, and it is 4:30 in the morning there. So I just wanted to say how much we appreciate you joining and how important a topic this is for all of us. So I want to extend a warm welcome, and I will turn it over to you to begin.
Thank you so much, Dr. Murphy. Thank you for you who are here this morning, early too. And thank you for the University of Dalhousie for inviting me today. This is a dense talk with a lot of information on the slides. The advantage is it's recorded. So don't try to read everything that's on the slides, or just listen to me. And then you can come back. I just want you to have a lot of information. You have a lot of article or talk you can access by scanning the QR code. So I just want to make that clear. And let's go. A few months ago, an artificial intelligence program called Midjourney was asked to create images of an autistic person. Out of 148 images, only 2 showed women, 5 showed men older than 30 years old, 100% were white, and not one was smiling. AI, artificial intelligence, works by integrating large amounts of data in order to answer our questions. Obviously, AI is not ready to replace us, or if they are, it's terrifying. As it is in this experiment, the information AI is giving us is a compilation of inaccurate and damaging stereotypes. Dehumanizing representations of autistic people and their families are not new. From Bethlehem refrigerator mothers being the cause of their child autism, to Lova's therapeutic brutality aimed at the normalization of children that he himself described as not being real people in the psychological sense, these portrayals have had damaging effects. In the recent decades, old myths have been challenged by biology, neuroimaging, and autistic people themselves, including the old myths of autistic people not having empathy or lacking theory of mind. Unfortunately, the dark shadow of false beliefs is still very present in our collective unconscious. Autistic people exist in every age category, gender, race, religion, culture, class, profession, level of ability or disability. Autistic people without intellectual disability, and that's the one I will speak about today, that's the one I know, are generally able to speak, to read, to write, and perform regular activities of a family. They can live independently. They can be your patients, your neighbors, your co-workers, or your friends. Many, however, have not been identified as autistic. In their 2015 seminal paper, Lai and Baron Cohen described the lost generation of autistic adults who were not accurately diagnosed in childhood and did not benefit from support. Autistic people live in a conundrum. If they are camouflaging their autism well enough and can pretend to be normal, in other words, if their disability is invisible, nobody believes that they are autistic. By doing so, society deprives them of proper support and misses an opportunity of having a more helpful representation of autism. But when under stress, the disability shows up, when the autistic person can no longer mask or control their distress or stim, when they become mute or have a meltdown, society, including healthcare workers, looks at them as willful, manipulative, and denies them adequate support again. For so many autistic adults whom I have seen over the last 9 years, the road to their diagnosis has been a long, often very traumatic journey, full of rejection and invalidations. But when an autistic person meets a psychiatrist, a healthcare worker that can get them, that recognize their autism, they're autistic, that believes them, then the relief can be tremendous. Autism doesn't explain everything, of course. And when you have met one autistic person, that's whom you have met, one autistic person. But being aware of their particular neurobiology is crucial when you try to make sense of what the patient is experiencing and how you can address it. Do you know that autistic people have an average life expectancy 15 years shorter than the general population? 15 years. The first cause of death is cardiovascular disease, like the majority of people, but much earlier. It's not surprising, as we know that most autistic people are living in an almost constant state of stress, fight or flight. The second cause of death is suicide. It's the 11th cause of death in the general population. Again, it's not totally surprising, as autistic people, 80% of them will have an important psychiatric problem during their life, and 60% have suicidal ideations during their life. Autistic women and men are in your clinics already, but maybe you don't know about it. They've not been identified as such. A 2022 study in Sweden estimated the prevalence of autism in a population of new patients, general population, sent to an adult psychiatric outpatient clinic is around 19%. 19%, almost 1 out of 5. And they think that they probably underestimated. Research shows also that autistic adults avoid consulting physicians because of their difficulties in making an appointment. A phone call can be very difficult, even for someone who is a professional recognized in his field. It's hard for an autistic person because they have difficulties to identify exactly what's happening inside of them. It's hard to decide if the symptoms are actually warrant of a visit to their primary care doctor, for instance. It's difficult for them to tolerate the waiting rooms, the noise, the light, the unpredictability of when the appointment really going to happen. and it's hard to sometimes communicate efficiently and being understood. These struggles explain in part why autistic adults are 3 times more likely to use emergency services, be hospitalized, and die after receiving emergency care. They often come too late or are not taken seriously because their facial expressions or tone of voice may not reflect the intensity of their distress. The risk is even higher for autistic women, who are almost twice as likely to die during an hospitalization than their counterpart autistic men, and 3 times more likely to die than non-autistic women who are hospitalized. So I hope that after today, you will be more comfortable, at least to consider that your patient might be autistic, in addition to the other problems, of course, they're consulting you for, and what it implies for your work with them. Let's now go to the slides. I don't have any conflict of interest. So how do I define autism for today? Here's, I think, a very good definition. It's a different way, we'll see it's a different neurobiology. It's the different way of perceiving, processing, thinking, learning, relating, and reacting to both what is happening inside of the person and the external world. I've given previous talks where I developed different parts like history and all that. Feel free to follow. These talks are available on YouTube because I cannot speak about everything today. So a few key facts to just attack the stereotypes at the beginning. Autism is, for me, a neurodevelopmental difference condition. I don't think it's necessarily a disorder, but we will come back to that. Children don't fall in a black hole at 18 and disappear. Autistic children become autistic adults. We are not generally trained about that. For instance, when we do adult psychiatry. 1 out of 36 people in the US, I calculate around 900,000, almost 1 million in Canada. We think 1 woman for 3 men or 2 at this point, no longer the 1 for 10. There is a surrepresentation of autistic people in the LGBTQ population, including transgender. We think that 10% of autistic may be transgender, which is 10 times more than the general population. If you see someone with transgender, think about autism. They have empathy. Not everybody has empathy in the non-autistic population, but not only they have empathy, we see they have hyper empathy. They have a theory of mind, it's just a different one. That's what was not imagined by people 30 years ago. And the range of disability, of course, and clinical manifestation vary depending of the environment and other circumstances. About labels, that's sometimes appearance can be deceiving, as I said in my introduction, and that's why the old labels need to be updated, I think. So when we say high functioning, it implies that the person has no problem in that adapting, and masking is not costing them, it's costing them a lot. And we see also in terms of cognition, sometimes we can be, an autistic person can be brilliant in a field of cognition and really not good at all in others. But because we see the top knowledge for certain things, we think that then when they cannot do something properly is because they're lazy. And it's a big pain for us. See a lot of autistic who are like brilliant kids and a lot of expectation for them. Then they couldn't really follow and consider it as what they didn't make enough of an effort, which really add to the suffering. And when you say low functioning or severe, that may dismiss the future possibility of someone. So many kids have been sent in institution, they were not talking at 3, 4, and parents were told, nothing going to happen. And I just want to quickly mention Elizabeth Bonker, who is non-speaking autistic person, stopped speaking at 18 months, was diagnosed autistic. Nobody really had much hope for her. Starting at 6, by pointing to letters, she was able to communicate. And you see her valedictorian in her high school 2 years ago, and she has no nonprofit to help non-speaking people all over the world to get means to be helped. So as you see, she was certainly in need of a lot of support, and these are the words we use now, high support needs or low support needs. And Elizabeth needs a lot of support for the first 10, 15 to 18 years of her life and can now live independently. In the last 50 years, psychiatry has moved from trying to understand the person inside and insights to consider the patient from a mainly behavioral, time-limited perspective, a Polaroid of sorts, which is limiting, of course, for the clinicians. Moreover, DSM's perspective is essentially based on the identification of deficits, which is also limiting. And as you see here, it's all about failure and deficits. When doctors say you're autistic and you check the DSM after that, when you come home, this is pretty scary. Some autistic characteristics also, like the ones you see here on these slides, are seen in the DSM entirely pathological, like adherence to routine or fixed interest. But if you see them from a different perspective, they can be qualities that made possible some of the men and women's kind greatest achievements in philosophy. You see Immanuel Kant, or science, as Marie Curie. I will put a lot of picture on people who have pretty seriously identified as autistic, even if it's people from the past. So if some of the cognitive particularities of autism that you see here, you can look them with a different frame. Sometimes it can be a big problems. If your attention to detail make you finish your PhD thesis in 20 years and you can never graduate, it's a problem. If your honesty make you tell people exactly what you think, including during a team meeting or when someone is asking you a question that you barely know, that's a problem. On the other hand, being passionate, being detail-oriented, developing expertise, fighting for justice, which is very important for many autistic people, can also bring you to have some kind of superpower, as Greta Thunberg would say. So I don't want to look, and please don't look only as a deficit model of a difference. Now, how can you identify autistic people? And we're going to go through these different sectors, perception, motricity, cognition, and so forth. And then we're going to look at psychiatric problems. The model of perception, which was added to the DSM-5, is very, very important. It's very important for you because these differences in perception are there for the entire life. So if someone is hypersensitive to noise, to smell, to light, to the point that they come to your office with dark glasses because the light really hurts, or they hear voices down the hall, that things that you're not hearing. These characteristics are there all their life. So if an autistic person has learned to mask their autism, right, they don't look autistic, they make eye contact. If you ask questions about perception difference, they probably still can tell you that they are indeed different. And as you see, it's almost 100% of autistic people. The other thing is that they perceive more, and so they have more to process. So processing sometimes can be slower. We think that autistic people perceive more than a person who is not autistic from all the information we receive constantly. Something that's extremely important also is the reduced habituation. And this has implication for treatment, for instance. So when you hear a noise and you're not autistic, even if it's a noise that's really annoying, you're going to stop hearing it, right? You get used to it. Well, autistic people in general don't get used to it. So they will continue to hear that really noise of a light and sometimes noise that other people don't hear constantly, which is exhausting, which is irritating, which is distracting. So that's also a question you can ask, but it's something you take into consideration, including in therapy, when we think that exposure going to help the patient. If it's an autistic person, it may not help them. It may actually be torture. Let's go quickly to different senses. So vision, as I said, sometimes very sensitive to lighting. So don't take it personally. Someone comes with dark glasses who ask you to turn the light down. Don't also feel upset if the patient doesn't recognize you. They don't do that to ignore you. 30% at least of autistic people have prosopagnosia, so they don't recognize the face. And the eye contact, which they have difficulties. And again, don't take it personally if an autistic person they don't look at you in the eyes. Looking in the eyes in itself for them is so stressful that they barely don't hear anything that you're saying. So when I see autistic patients, I always tell them, you don't have to look me in the eyes. Sometimes we do, more important moments of the conversation, but I know that if they don't look at me, they can concentrate more on what they're saying, and they will hear what I say better. It's not easy to get used to it, but it's true, and studies show that when you force people, autistic people, to look in the eyes, their amygdala really get hyperactivated, and amygdala is the center of fear, which is also looking back when we force children to look adults in the eye or people in the eyes to normalize them. It's a very bad idea. Hearing, hypersensitivity to sounds, delayed processing. So you have the same thing for all the sense that we want to look at it. Delayed habituation. So we want to help patients to get used to the supermarket after a long hospitalization. If they're autistic and you force them to go in noise and sound and light, you're just ready for a meltdown. That's not a good idea, once again. Very important, they're very sensitive to the tone of voice. Even if your tone of voice you think is normal, you're not really upset, they really sometimes may hear it as if you are really angry, as if you're yelling at them, even if you're not. On the other side, they don't always control their own tone of voice. It may lack of expression, or it may sound angry if they are not angry. And again, all this may complicated interaction. Again, same around smells. And you probably all know someone who can really not tolerate a certain perfume or a certain smell. It made them physically sick. Again, for some people, this is just true. Believe them. Touch, and I developed more this sector in my other talks. As you know, a light pressure can be experienced as very painful. On the other side, you can have hypersensitivity. So, for instance, to cold. I know someone who was running in the cold in London in the winter, with barely a t-shirt, and the person was in great shape and had a heart attack as a result of the cold and the vasoconstriction. He had no risk factor at all. His inability to perceive that what he was doing was potentially dangerous almost killed him. Pain, atypical perception. Again, some may not feel the pain or not identify that's painful enough that it maybe warrant a visit to the ER, or at other time, the pain is actually extreme, even if it doesn't seem that's something that should hurt you. A light touch can be intolerable for some patients. Very important when you do a physical exam, when you check a blood pressure, always ask people if you can touch them and explain to them what's going to happen. Something that's not unique to autistic people, but that's very frequent, it's alexithymia. So the difficulty of being aware of what's going on in terms of emotion and physical sensation inside. And again, all that complicate communication. And that's where some physiotherapy or exercise, corporal therapy, and talk therapy can really help. Because for a lot of what I'm describing today, you cannot change certain things like habituation, but there are other you can really teach in therapy to identify, for instance, emotion, to put a names of what's going on inside of you and help. And when the autistic person learn these tools, they learn them like borderline patients. So you don't need to be a great psychiatrist to imagine that if you're hypersensitive, hypervigilant to sound, to noise, to all what's happening around you, a little further than you, that can be source of a lot of anxiety, sometimes create meltdown. As you see the sign here, you can have an increased stimming. People may suddenly talk faster, think when they're in an emergency room, for instance. They stop, they cannot talk anymore. All that are red flags. We need really to calm down, try to find a quiet place to work, and not push the patient. It's not that they don't want to cooperate. They cannot. They are overwhelmed. Other things you need to identify, it's in terms of motricity. Often a very difficult handwriting, fine motricity is difficult. It's also difficult to play, to catch ball, throw ball. You work in a strange way. You can imagine all that will be source of bullying for a lot of kids. Interestingly, some sports are good. Swimming, golf, horseback riding, or that are a sport that can be really done with joy for autistic kids and adults. And catatonia, so when you see catatonia, it's not just bipolar or schizophrenia. 12 to 20% of autistic people have catatonia. So that's very important, again, when you make a diagnosis. In terms of cognition, I think the best way to understand is that autistic people have a different operating system, right? Some have Windows, some have Mac. The way you receive, you interpret the word, you communicate with the word is different. They also have an asynchronous development. So some skills are excellent and develop early, some very late. A lot of autistic people, kids, speak very late and then suddenly speak properly. So we don't speak so much as a spectrum, as you see, as a mixing board with a lot of sliders. And that's why you have this spiky profile for autistic people when you do neurotesting. As you see, this kind of roller coaster of a test. So they are excellent in verbal skills and the working memory is terrible. Perfect visual skills, processing is very slow. That's a typical spiky profile of an autistic person. Think of what I said earlier about the high functioning. You can understand why they can be very high functioning, doing very well in certain fields, but not at all elsewhere. So how much need do they need where? The non-autistic people have a more even profile. So they're more predictable in terms of competence. Attention, ability to hyperfocus, which is fantastic sometimes. They can work for 12 hours, be in an operating room for 8 hours, don't need to eat, don't need to drink, anything like that, or don't realize they need to. But it can be, of course, great issues. You don't take well care of you, and you have difficulty shifting attention. A lot of autistic people don't do the pause at lunch to speak with their colleagues, in part because they don't want to lose the stream of attention and focus they are in. Perfectionist, but then you can be stubborn and persist in strategies that are not good, even if everything and everybody is telling you you're wrong. They have great pattern recognition, can make connections, which is fantastic. It's probably why Einstein made all this discovery at 25, but it is exhausting. Problem with memory. Autobiographic memory is not good, particularly if you don't give hints. Important when you ask questions. Monotropic style of knowledge, so they know things one way, and they're fascinated by one subject. Again, yes, this pro and cons. Often problem with executive functioning, and since many people who are autistic have also ADHD, that's really doubled the problems. You've heard probably that autistic people see the trees before the forest. I don't see it's necessarily bad. We need people who see the forest first and also who see the trees first. The fact that you have this bottom-up thinking, we need to look at all the trees, all the leaves before we see the forest, may have is good point too. That means that in general, autistic people don't take things at face value and question assumption. We can be really enriching or annoying. They can also be more creative. They don't necessarily have a preconceived plan of what they need to find, and that's why they may be thinking out of the box. And that's why we have, I think, so many inventors who are autistic. The language is different too, it's form of culture, right? Very literal. So if you ask people if they hear voices and someone is speaking far down the hallway, clarify that they hear voices down the hallway or they hear voices inside their head, right? Because you can, again, misdiagnose someone with that. Style seems pedantic. I like to call it sophisticated. You see James Joyce and Beckett here. I don't think they create, they just wrote the way things were coming into their mind. Fewer emotion-laden word, difficult with intonation, as I said earlier. At work, one of the first accommodations is to tell people, write clearly what the person needs to do. It's much helpful. Social interaction, that's, classic, no small talks, they don't like lack of precision, they don't like when things are not predictable, they don't follow the rule of conversation of we speak and then the other one takes turn, right? Tend to be brutally honest, which make them look like rude. Great sense of justice. Often, so many have been whistleblowers without even realizing that's what they were doing. Difficulty with sarcasm doesn't mean they don't have a sense of humor. And if you follow Anna Gadsby here, she speaks about her own autism in really funny and totally real terms. They don't necessarily see that someone needs help, and they have difficulties asking for help. And if you don't see that someone needs help, or if you are very frank when they ask you questions, it can create the problem that people think you don't have empathy. But you have to differentiate the two different types of empathy. You have cognitive empathy, it's an intellectual empathy. You know that someone lost a dear friend, they will be sad. Even if they tell you they're okay, you assume they're not. So it's more an intellectual, cultural way of having empathy. And psychopaths are really good at that. Autistic people in majority very bad. They have to learn. That's one of the things that doesn't come intuitively. They have to learn it. But then you have the emotional empathy, the empathy of the heart. How we react emotionally, knowing that someone is in distress. And generally, actually, autistic people have hyper empathy, not only for people, but for animals, even for objects. So the old story was that when an autistic and a non-autistic person were interacting, the lack of communication and empathy was the fact of only the autistic person. But communication is a two-way street, and many studies and research have now shown that people with a similar neurotype communicate and understand one another better. So autistic people get one another empathy type and theory of mind, as non-autistic people do. So the problem is not a lack of empathy, it's a difficulty or a lack of mutual understanding. Something very important, again, when you don't understand the world you are in, when you are passionate about things, when you can be overwhelmed, you don't sleep well, you can have meltdown, you have difficulty to control your emotions. That's one of the reasons why so many autistic women have been diagnosed as borderline personality disorder. Autistic people are not flexible in general, so that may give them difficulties to know how to react, and they may sometimes go back to use maladaptive emotion regulation strategy that not fitting the situation and gives a lot of problems. One of the problems is the meltdown. It's called hysterical, right? And that can be scary for the entourage and in your ER. Yelling, wailing, screaming, rocking, all these symptoms. This is not tantrum. A meltdown is something the person cannot stop. They cannot. You can tell them whatever. They are full of shame. They lost control. It's a terrible experience, and they cannot stop it. So I think that's very important. That's why we need to try to prevent it. We need to be aware of the triggers. We need to try to, diminish the triggers possible. That can be, we be attentive to what just happened, a loss of a person, an animal, a routine. And when it happens, things GPS, right? The GPS reorients you, redirect you very calmly, even if you keep taking the wrong road. Stay calm, identify triggers, minimum conversation, avoid touching the person even, except if they are in danger, and explain what you're going to do. This is one of the something that'd be surprising. You have a colleague physician who is brilliant, and suddenly, for a kind of circumstance, totally fall apart. That can happen, and here's what you can try to do to help. Self-harm is very frequent In autism, that's why, again, confusion sometimes with borderline, 3 times more than general population. Like the general population, it's to help regulate emotion, particularly depression or anger. It can be also a form of self-punishment. And alexithymia, so not being able to identify what's going on inside, depression and so forth, can increase this self-harm behavior. That's where, again, therapy like DBT help identify what's going on. It's really, really something we can try to do. Shutdown, catatonia, when it's at this extreme. So sometimes happen before a meltdown, like a sleep mode in a computer. Suddenly the person seems different. Their speech change, or they don't speak, they're staring, they look absent, almost like a mini seizure. And it's really a way where they're totally overwhelmed and they just close up. They're going to go and isolate themselves and nobody will see that way what's going on. Triggers the same as previously. And what you do again here, give safe space, sensory friendly, make sure they have everything they need, let them sleep, sleep, sleep. Now, when you try to identify the patient for the first time, you want to look, okay, what I'm looking at if to make sure they are autistic or not. Well, you look at everything that you look normally with a patient, but you may pay attention to some, right? More difficulties with telling the story, sensory system, special interest, what's happening, history of meltdown. People sometimes disclose with a lot of shame and difficulties. So you look at all that. You also ask about medical co-occurrence. A lot of medical problems are more frequent with autism. And for instance, if you hear about Crohn's disease, about Ehlers-Danlos loss, think about autism in the opposite way. If you have an autistic patient who has some flexibility problems, some chronic pain, think of referring them to a specialist to identify Ehlers-Danlos loss, for instance. A lot of dysautonomia, a lot of long COVID, a lot of vitamin deficiency, sometimes because of the way they eat or don't eat, sometimes because of genetic differences. B12 is a very big one you need to check, and remember that a lack of B12 can bring in itself tons of psychiatric symptoms, including delusions and hallucinations. So very important to check that. Psychiatric co-occurrence, well, you have them all the psychiatry book, right? It's a difference, but you still can have everything that non-autistic people have. Again, you can go in details to these studies, but as you see here, ADHD, anxiety, sleep disorders, all that is extremely frequent in autism. And let's look at them quickly. Sleep, more insomnia, less REM sleep. Very helpful sometimes, some of these apps. It helps them if they don't have a good sense of, did I sleep enough or not enough? That can help them to regulate it with an external perspective. Melatonin disruption, right? Remember, it's an hormone. That's something we give a lot to autistic people, melatonin and magnesium. Anxiety is kind of present for most autistic people. Remember what can increase this anxiety and the risk of meltdown, for instance, unpredictable environment, things that are not logic, right? You may say, I'm coming to see you after lunch, give you meds after lunch, and then you don't eat. And you come and give the meds, and the autistic person says, but you told me it would be after lunch. You've not been eating. How come you give my meds now? Things that seem silly, don't make sense, and they seem the patient is difficult. When you look through the autism lens, then it makes more sense. And if someone is hospitalized, dysregulated, all these things will be more difficult. Remember that traditional CBT that ask a lot of abstract thinking and also sometimes force you to get habituated to some things that are difficult may not work, may be totally counterproductive in autistic people. ADHD very frequent, and it's very complicated when you're autistic and that bring you inside, and ADHD you go more impulsive and going outside, difficulty with executive function. Again, someone with ADHD, women that are a little more diagnosed now than before because we see them. Think of autism. PTSD is extremely frequent, right? When you are born in a world that you don't understand intuitively how this word function or the social language is, what are the traditions when we speak with someone, for instance. all that can put you at risk of a lot of misunderstanding, microtrauma, macrotrauma, abuse, sexual abuse. We know that women in particular are much more at risk for that when they're autistic. And remember, prolonged exposure may not work. I remembered later on, I realized with a patient who with prolonged exposure, she did her best, and her blood pressure went up to 220 each time after we try only twice, prolonged exposure. She was not able to tolerate it. Mood disorders are very frequent, and you have a little more of bipolar when you're autistic and vice versa. Here you see come back, look what's in common, what's different. Again, autism, special interest, repetitive behavior, neurodevelopment, stimming, or that is helping you to think if the neurobiology behind that is autism. Factor that increase suicidality, the perseveration in autism, the logical, well, it's no solution. My only solution is suicide. So those are really things you want to address, and you want to be careful. Camouflaging, trying to pretend to be normal is a high risk for increasing suicide and burnout. There is something we call autistic burnout, which is slightly different than regular burnout. And in autistic people, you see a loss of skill, very important loss of skill, and an increase in sensory sensitivities. So again, why is it different? Well, because as much as in depression, for instance, behavior activation can help, it's not the case at all in autism. You can actually make things worse, right? The treatment is mostly go home, rest, sleep, 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 right? No stimulation. Borderline personality disorder is important because it's a lot, as you see, in overlap between autism and BPD. They have all these things in common: difficult relationship, apparent lack of empathy, emotional dysregulation, poor sense of identity. So that can, and you can be borderline and autistic. And actually, if you are, this is increasing greatly your risk of completed suicide. So when you try to diagnose, again, importance of routine, special interest, perception, I hope you know by now. And we have a couple of books you can find where we adapt DBT skills for neurodivergent, meaning for autistic, people with ADHD. And patients, I recommend the book to find it's very useful. Narcissistic and antisocial, as I said, sometimes, you don't have emotional empathy, right? You have that in autistic too. And you may not have no empathy at all, antisocial, not at all emotional empathy, but a lot of cognitive empathy. So you know to manipulate people, but you don't care at all of what's happening to them. So try to identify. A lot of autistic people seem very narcissistic when they correct you because they're expert in the field. They do that without any grace and may look and may be very narcissistic. OCD, very important, a lot of crossover, very important. The rituals in someone who is autistic are soothing, egosyntonic. So the rituals are actually helping. It doesn't bother them at all, or their compulsion. And they can go from one to another, which is different with OCD, where you suffer and you're in pain because of this compulsion. A lot of eating disorder, different way to eat, but also need for control, hypersensitivity, all that can play a role. So pay attention, think of autism too when you have a patient with eating disorder. Substance abuse has been less studied until recently, but we think that they are twice more likely to be addicted, which makes sense too, right? If you need to mask, a good way to seem you fit in an environment is to drink a glass of wine or two. And then, of course, for some, like Joyce Highsmith, that becomes alcoholism. Anthony Hopkins, who was diagnosed autistic in his 70s, has been 45 years sober. It's very important. The diagnosis that really help people to stay sober. They realize why they were drinking and made, change their environment and what they do, and that will help them to be sober. So here too, it's important to identify. Schizophrenia, again, a lot of things in common, but delusion, hallucination, clearly it's in schizophrenia, not in autism. No, autistic people may be passionate by some subject and seem very esoteric, but they may be correct. So special interest, sensory difference. Remember, I hear voice, yes, but the voice are really there. Maybe other people don't hear them. You see Edward Einstein, the son of Einstein, who wanted to become a psychiatrist, then fell apart in his 20s and was diagnosed as schizophrenic and died in a mental institution. Not sure he was schizophrenic. Maybe he was autistic. Here you see, when we want to improve our chance to succeed, when we work with autistic patients, we want not only being able to communicate with them, understanding better, and improve the milieu, right? The room in which we work together. And so I want to share with you this paper published by Dr. Mary Doherty and her colleague. They're part of an organization called Autistic Doctors Internationals. Yes, they are autistic doctors, actually almost 1,000 in that organization. It's a support group, but also quite academics. And this is a paper that was published by them this year and explain how have a framework to facilitate access to care using, as you see, this acronym. It's very useful. Just go check that article. It's very simple in the way it's writing, very clear. I think it can help you. It's a lot of things I'm sure you're already doing, but some also you may have not been thinking of. So in my last 2 slides, I want to share with you what you can do to improve the chance of success. A lot of things I've said already. Be calm. And it's not just with your patient, by the way. It may be some friends you meet and you've never understood because they never look you in the eye when you speak, right? Believe the autistic person. Don't assume a bad intent. Be very clear. Make sure you were understood. People are very, very literal. Give time. They may need more time to process, right? So try to be flexible, including in the therapy and the technique you're using. From medication to technique, if you see it increase the distress a lot, maybe that's not the right technique. Medication is something else, so you want to really look. Treating the co-recurring disorder may be enough. We don't treat autism necessarily, because so people are, right? But people are generally very sensitive to medication, to side effect. I always start at a very low dose, take my time. And if people don't tolerate the medication, trust them. It's unusual. Yes, they have an unusual brain. So that's explaining a lot of things. Be curious, be curious, be curious, and believe the patient. In conclusion, too many autistic people die too early, suffer too much from psychiatric and medical ailments without necessarily being able to get the proper support. Identifying autism brings relief to everybody because it provides a new framework to understand better long-standing interpersonal, social, physical, and sensory perceptual difficulties. Remember the double empathy problem. Getting to know one another is a two-way street, but not an impossible task. Autistic and non-autistic people are different, yes, but they have also so much in common. Considering autism, when you work with a patient, can make a huge difference in terms of easing the work together and lowering the risk of an early death. I hope sincerely that this task will contribute and help you to make a difference. Thank you very much. I'm putting 2 more slides, one with movies easy to watch and some books I recommend. Again, you can go back to that later. And to reference. Thank you. Stop sharing my screen. All right.
Thank you so much, Dr. Grosjean, for your excellent presentation. I know we talked earlier. I know how challenging it was to limit the massive amount of information and what you typically present to 45 minutes. So I think you did an excellent job. Thank you so much.
Thank you.
So we do have some time for questions. So as always, if people want to type their questions into the chat, we will work our way through them. So I see there's already one here. So thanks for this wonderful presentation. So the question is, given the relative lack of cognitive flexibility and a tendency to be more or less rigidly focused on one way of thinking about a problem, are autistic people more vulnerable to political propaganda and or conspiracy theories? Not that non-autistic people are not, but it seems like they might be more vulnerable to manipulation in certain situations.
Probably, yes. I mean, you know, they can be passionate in both sense, right? So we use Greta Thunberg. Yes, I think again, you have all kind of autistic people, all kind of non-autistic people, more or less sensitive, depending of your level of education, flexibility. And but I agree that's important. And you can be brainwashed, particularly if you don't have access to many different type of information. So I suppose I don't want to push into the stereotype too, and thank you for saying that it can happen to every type form of people. But yes, often I don't know, the people we hear about in politics and history were often like pacifist, often things that we would look in a way that's less destructive, but not always, right? We can assume, is Trump autistic, right? Was Hitler autistic? God knows. So we have all kind of people in both sense. Sure, rigidity can make things worse, and then if you become your special interest and you look only one television, then yeah, one cable, yes, it's possible.
Thank you. So there's another question here. Thank you for the presentation. Could you comment on assessment for autism in an adult who meets criteria for schizophrenia?
Well, why do they meet criteria for schizophrenia, right? So that's what you want. And you, again, you can have both, right? And some say maybe we have an increase of bipolar and schizophrenia when autistic, like 2 or 3 times more than general population. I really think that's where the developmental history is very important. The family history, any schizophrenia in your family. So many patients I see had a grandmother who was, hospitalized in a psych place, and we took they were schizophrenic or bipolar, but they came back home at 50. It was no medication, or at 70, and they were fine. So I would look at the history, the developmental history. How was school? How were you socially? Did you get what's going on around you? And then, of course, when did things start? A big confusing problem too is confounding is drugs. A lot of people use drugs, and this marijuana, which is so strong. No, I've seen patients both from triggering episode of schizophrenia, but a lot of autistic people are using CBD. By the way, CBD very bad with lamotrigine, and a lot of other medication can increase the levels. So look for drugs. Last things, in general, if they're autistic and not schizophrenic, antipsychotic don't do anything except making them more autistic. So you have to look at all these things.
Thank you. So there's lots of questions. Could you elaborate more on the suicidal ideation, quick resort to suicide to manage difficult emotions and situations?
Yeah, I don't know if it's necessarily quick, but as you see, 60% think of suicide. There are studies showing how much, for instance, if you go to this Autistic Doctor International website, you see other studies that with doctors, practicing doctors. Some were diagnosed very early in life. A lot get their diagnosis after their kids was diagnosed with autism. And you see that in the population, no, and we know doctors and women are very at risk for suicide. So it's pretty frequent. And doctors have the mean. Maybe I don't totally answer your question. The rigidity, I think, is when people are very logical. I lost my job, my partner left, my kids don't need me, the world is falling apart. Why would I live? Particularly if you're depressed, right? And it's very hard when you work with patients. I think, like with borderline patient, you want to let them express it without panicking, without sending them in an ER immediately, because you may never see them again because you lost the trust, right? And really try to enlarge the field of what else can happen, to recontextualize, to look at what are the values that are important. But it is difficult, and there are these suicides that are, just happen, and it's not much you can do. So it is complicated. But again, knowing that the person is autistic, and if they're, you can educate them in quote and share with them more about that, and suddenly their life makes more sense. Then they are so more aware of their own mechanism, of their own cognition, and can work with you in changing perspectives, for instance. That's why I think it's so important for you to be knowledgeable, but for the patient to be knowledgeable about themselves. It's like someone who has an allergy, right? You want them to know about it. It's not a mystery.
There's actually a couple of questions here that are similar. So I apologize, Natalie, if I don't read your question specifically, but I think you and Jason have similar questions. So they're asking about numerous young people recently seeking a diagnosis of autism to explain a feeling of not fitting in or succeeding in the way they want in their lives. Typically, they have few symptoms to support such a diagnosis, and they become very angry when you don't agree with this explanation in clinical experience. Um, in my clinical experience, people where I make a new diagnosis of autism, it comes as quite a surprise to them. And so I think they're wondering about whether you can comment on that trend. And do you find people are recognizing themselves accurately in social media descriptions and portrayals?
Yeah, the big subject, and I think we have a clash of generation, right? I was not trained. I was trained twice in Belgium, in the US. I was not trained in adult autism. Autism were these kids, like God knows what they go after, right? And people we never see in the clinic. So we didn't have that training. We don't know how to identify them. And then you have young people, as I said, a lot of colleague autistic doctors. They get there, they say, "Oh, that's autism. Well, then maybe I'm autistic too," right? So you have young people who have been identified, and I'm going to come to TikTok later, who have been identified, come in college, in high school, get some support, want to continue a career, for instance, in healthcare, and are told, yeah, you're autistic. You're not there of mind, no empathy. How could you become a nurse? Right? So you have this clash, and people don't see them as autistic, and they're very angry. Right? So that's one issue. And I think this is something we have to take into consideration. And then, yes, a lot of young people or others look TikTok and all kind of places where they have information and come to the psychiatrist and say, I think I have ADHD or I'm autistic. And what really pained me when I'm on some Facebook group for physicians or psychiatrists to see the anger of my colleagues and how they make fun of young people in pain, trying to find something to explain what's going on, to explain where they don't fit, and just discard what they propose immediately. They may not be autistic, I don't know, but why don't we listen to what they think, why they think that way, and try to understand? So I remember a neuropsychologist expert in autism that I was speaking with, who have 30 years of experience, and who told me, I never saw someone who identified themselves as autistic and who is not, right? Maybe some exception. And why would you do that, by the way? Why would you do that? Right? It's a little bit like before, say, well, my son thinks he's gay, but he cannot be gay. It's the fashion now. Everybody is gay today, right? Well, we know that was not totally correct. So I think that people hear about some characteristics, as any teenager that can have, again, a focus on something and then change their mind. But I really want to take that into consideration. We're not hurting anybody by looking at it, by exploring the sensoriality, the history, and all that. And if it's autism, again, the one who really sometimes I've never thought of it or I've been thinking of it, but never dare to tell me, some patients, that they took of it for the full year when they were seeing me, because last time they said that to a psychiatrist, they were ridiculed, and it's sort of hard enough to come back to a psychiatrist. So people are worried about sharing that with us. So it may be a trend. I think we speak about autism differently today than we were 20 years ago. And again, I hope my talk show you why it's important. It's not just to put a different hat on the head. It means the head is different. And if we take that into account, people can really be helped. And we can really change this early death and risk for suicide. And what I've seen is how people look at alcoholism, right? People, that's why I'm sober. I need to be sober. That's why I'm staying sober. Next time I go to this big party, I tell my husband I will leave after 1 hour, because too much can overwhelm me and I no longer drink. So more knowledge about ourselves is helpful. And if it's wrong, then it's interesting to know why they want to be autistic, right? Whereas we have to be curious.
I think we have time for one more question, and then if people need to leave, I understand that. But Dr. Grosjean has very kindly agreed to stay on a couple of minutes extra, as I anticipated there might be lots of questions.
As long as you need. It's 5:30 a.m. here at time.
You look much more awake than that. So thanks so much for this excellent presentation. Could you please comment on the role of sensory profile assessment in the management of autistic patients with severe challenging behavior?
So when you feel severe challenging behavior, I suppose you speak about autistic people with high needs. So I'm not sure which type of assessment you're speaking about, and so I apologize for that. I think that's personally, or I would assess, and I probably would assess differently in my quiet office that in on a ward or an emergency room. It's just supposed about checking all these different realm of perception that may be source of a lot of stress and discomfort or pain for the patient, and try to take that into account. I used to work at Harbor UCLA, which is a gigantic county hospital in LA. I'm sure you have that in Halifax too. The ER is a sensory nightmares for everybody. Everybody works in it and is burned out quickly, and of course for patients. I think that's part of where knowing more about autism can help us, including to work with administrative and say, it's important we have a quiet room. We will lose less money in staff putting people in restraint because we have a way to help them to calm down more easily. So I apologize. As I say, my expertise is autistic adult without intellectual disability. Now, the meltdown can be pretty destructive, but I don't have enough time and enough qualification maybe to answer this particular question. Still spoke a lot for it, though.
So there are a couple more questions and comments. We are at time. So Mandy, I don't know. Usually if we go a little bit over, we'll invite people to turn on their cameras and mics and have a bit of a conversation as we work through the final question. So Mandy, if you want to allow people to do that if they choose, that would be great. In the meantime, the next comment is about, I'm curious if you've watched the television show The Good Doctor, and if so, what are your thoughts on the accuracy of the portrayal of the lead character, a young doctor with autism struggling with challenges in the field?
I've not watched it yet. It's on my to-do list. I've not. So I apologize for that. I heard that it was more a classic old Asperger. If you take my other talks, I speak about the history, right? We don't say Asperger anymore because he sent so many kids to their death. But it was a very useful stereotype, but essentially for men. So it was useful for them, absolutely not for women who were not identified. And but I think some of my colleagues, I'm sure we have some people that we know that really fit the model. And I think we let men with being stereotypical more than women. And I think that's a big issue. When I said earlier why so many women die, including in the hospital, more than men, is because we don't believe women when they say they're in pain. It's well known, and even more if it's African-American women, for instance. And we give men a break. Oh, it's different. He doesn't stay for dinner, doesn't smoke, is kind of rude. Yes, but he's very smart, right? If a woman behave in the same way, she's considered as borderline or hysterical with a negative connotation of borderline. So that's an issue. So I'm sorry. Maybe for next time I will have watched it.
And this is just a comment, but I wanted to share it with you from Nicole. As an autistic student in the department, I thank you very much for this incredibly accurate and detailed presentation. And I'm happy to see the department integrating autism education into adult psychiatry. So I just wanted you to hear that.
Thank you so much, and I'm happy I hope you could feel it. This is so important. And once I said you need the eyes need to learn how to see and what to look for. I think with this in general, you're probably going to see a lot of autistic people around you. And patients, and it's helpful. I remember one time, my wife is the one who reads all my talk and makes sure my English is correct. So she's pretty knowledgeable in autism. She was telling me once she was at a party and someone spoke for 45 minutes without making eye contact once. And it was a fascinating conversation. And she told me, because of what I learned because of you, I could enjoy the conversation without constantly thinking, Is she listening to me? Why is that not making eye contact? What, as this person wrote, he said, no, I knew that she was fascinated by the subject and she was totally in contact with me, but not by eye contact. So knowing that really help our countertransference too, as healthcare provider. And that's so important.
So I think one more question here. Very interesting presentation. Thinking about the example of people who are gay, do you think that being autistic is essentially something people should define or identify themselves? If so, what is the role for psychiatric diagnoses?
I don't know if it's essentially maybe less. I mean, sometimes people think they're gay and eventually their life will go to another direction and they explore it, not in a punitive way, of course, right? But you may explore and you may be bisexual or maybe, so but I really like the analogy of being gay because it's how we are made. It's biological, right? It's at least big biological than environment. I don't say the environment as an influence, but some things it seems that the environment cannot influence as much than for others. So I see autism that way. I really feel in general, people who identify themselves, they have in their mind their entire life all these black holes of sudden interruption of friendship or bullying or understanding why they lost that friends or they lost that job. Suddenly everything makes sense. And so in general, I really think that people are probably correct. Again, if they're not, we can explore with them. And the family story is helping so much too. I think one of the reasons it's difficult is all these stereotypes. But I'm not again, and it was these neuropsychologists I worked with who were the first to tell me. But again, why would someone say that, right? Why would you say you're gay if you're not? I mean, maybe some, very, I don't know, so psychopathic reasons, some professional, but most of the time it's no reason to say that. So I would really believe the patient. I mean, patients come, remember, it's like if they come to you, they're saying they're in a lot of pain, they don't show it. And the appendix may have burst, and so why wouldn't I trust? And with my knowledge as a doctor, as a psychiatrist, I may ask questions that's going to help us to guide us to a proper diagnosis and what it means in your life. And is it really autism was a problem, or is it ADHD, or is it the trauma, right? So it's if it's a trend that the patient is better educated and is bringing us more possibilities, I don't think it's a bad trend as long as we know our craft very well. And we don't say yes to be nice to the patient, but we explore with them. I think it's funny how the medical establishment, maybe because we've not been challenged for centuries, have difficulties with educated patient coming to us and say, do you think I may have Ehlers-Danlos? Do you think my problem may be this or that? Again, if we know crap, we can, why not? Let's explore. Well, let's see. So I have the same attitude vis-a-vis autism.
And I think her follow-up question related to what you were just saying is, would it be reasonable if patients ask if they are autistic to say that they can decide for themselves most of the time?
For sure. I mean, if they want to decide for themselves. But again, autistic as you saw today, and I think it's the next DSM may bring some change, doesn't mean you are sick. Right? It's not an illness, right? That's why I say autistic people and not people with autism, right? The old way to say it was like autism is this stuff that we can remove, like someone who is a person with homosexuality or with womenness, I suppose, or with thing. So that's who you are. Again, what is it? Is it that they want to apply for disability? Well, then, we need at least a good informed psychiatric opinion, maybe testing. If it make their life, if they find their people and they're comfortable with that and give them ways to take better care of themselves. Again, it's true. And if I really think that's really weird, I mean, they really don't want to recognize that they're bipolar 1 here and they need to take the lithium. Well, I'm going to speak with the patient about that too. I don't feel threatened by it. The patient can come to us and say, I think I'm schizophrenic or I think I'm borderline, right? And what do? We do our job. We look with them and what's going on. And if they don't like it, they can see someone else and Yeah, I don't see it as a big issue. Not as big as some make it.
Lots of comments thanking you and commenting on it being an excellent presentation, very helpful and informative. So I just wanted to let you know that. And then there's maybe one other question here, and then unless anybody has any last questions, I don't want to keep you too much over time.
I'm fine. I really am fine. I would tell you. It's my favorite subject.
This is from one of our residents. So I've noticed that autistic people seem to commonly get themselves in trouble for harassment with complaints or criminal charges for harassment, and yet many seem to lack insight into the extent that they're bothering people, especially where autism can so often be missed and is left undiagnosed. How can we distinguish between harassment that occurs due to being triggered, followed by impulsivity of executive dysfunction in autism, versus harassment that occurs as a result of rigidity and perseveration on ideas? Oh, it's a long question. Versus harassment that results from restrictive and repetitive. I think how can we distinguish where that might be coming from is essentially the question.
Well, first, it's very important to identify it, and that harassment is not a good thing, and we need to teach people, autistic or non autistic, that's something that needs to be under control. And now knowing if someone is autistic or not, will help. Because if someone is harassing someone else without knowing that's harassment, and we're able to identify with that person, and we're able to taking time, sometimes it doesn't change quickly, but realize, help with the context, help to try to imagine what's happening in the other person, because an autistic person may not feel that again intuitively. And if the person who is harassed is not clear, remember, autistic people need message to be very clear, very literal, right? So if they ask you, is it bothering you? You want to say yes if it's bothering you, right? If you say, that's okay, the autistic person not going to understand. They will say, oh, it's okay. I can continue to send this message or following them home, things like that. This is one where young autistic people and less young have problem with the law and have been arrested for that. You want to see, is it delusional? Right? Is it something that we may need medications and help? Or is it really this way of thinking and perseverating and rigidity and impulsivity that maybe not only therapy, maybe need some medication? Maybe you need SSRI if anxiety is precipitating more of these compulsive behaviors. So I think it's again variable, but it is a big issue. Yeah, I didn't speak about that because I don't speak about everything, but we want to identify again. You want to see if the behavior is made in good faith, in quote, if the people really don't realize that it's problematic, or if they know it's problematic and they continue nevertheless. So it is a very complex problem. Hello.
Bonjour, Bernadette. I'm so grateful for your presentation. So I'm a psychiatrist who does this work. So I work predominantly in autism. I'm a child and adolescent psychiatrist, but most people that come to me for diagnosis are generally older teens who've been missed or have a kind of alphabet soup of diagnosis before they come to me. I also specialize more in females and female identifying youth and youth on the LGBTQ spectrum or transgender youth. So I'm curious, in your expertise, one of the challenges that I run into not infrequently is that the diagnostic tools that I've been trained on, the diagnostic tools that, our psychologist colleagues have been trained on, aren't well validated for these populations. And the screening tools generally don't work well at all. And so I am diagnosing a lot of times based on a lot of different areas of information. So chart reviews, developmental histories when I can get them, unless a child's in care, psychiatric interviews, and using the ADOS and ADIR when I can. I'm wondering if there are specific tools that you employ and find most useful, or is it just kind of taking Gestalt and what you can?
Yeah, it's interesting, isn't it, that we can, as psychiatrists, make diagnostics for everything except for autism, right? Especially for ADHD, right? We can identify very complex multiple pathology. And I think it's historical, right? It was children, it was the field. And don't get me wrong, neuropsychological testing are fascinating, are extremely useful. The problem is we have years of wait list, and it costs, in California right now, it costs $6,500. And it needed, I mean, the psychologist does a lot of work. But it's, so, and I've asked it a few times, but otherwise, I really think, and that's why, I'm up at 4 a.m. to give this talk, because I think psychiatrists need to know, because you cannot diagnose if you have no knowledge, of course, but be informed, need to know. And right now, that's how the diagnostic is made. Indeed, the tools were made for little white boys, right?
I think I said that exact same thing during the presentation on this topic in the spring. It's so true.
Nothing against young white boys, but gosh, we have such a diversity. I mean, I work in a nonprofit in Los Angeles with really immigrants, poor because they come here, and so many. It's interesting. The child is in the Los Angeles public education system, and they are diagnosed as autistic. And then I can show the team. I say, "Look, mom, it's not just PTSD," in quote, right? It's not. We have this. So what I hope is that, autistic researchers and non-autistic researchers and women and minorities are so involved now that I hope we're going to have better tools. But, a tool is a problem, right? Because if it's become a page that people have to click, then we may lose the clinic. We may lose the 3 dimension that we have. We do an interview when we see, a little concrete here, right? I said that to me, say, all what we do as clinician, which I said, I find myself a clinician. I think it's so important. Robots are not ready to replace us if we have only lists, and that robot may replace us. So no, I don't use different tools. I hope some other people who do that very well, better than me, will create one. And still, it's just a tool. I think clinic is so important.
Yeah. Okay. Thank you for validating at least what I'm doing. Thanks, Cheryl.
No problem. So I don't see any other questions in the chat. I don't know if anybody else who's stayed on has other questions or wants to pop on their camera and mic and ask any questions.
Well, I'm very happy people were touched by it, and it speaks to your Celia, to your experience, and to this students, and it really help. It's less of a mystery, it's less of a drama, becomes something that we all encounter. How someone's showing up.
Yes, hi. It's a Dr. Singh, actually. I'm a inpatient psychiatrist in Sydney.
Hi.
Yes, hi. Sorry, I am driving. I thought I wouldn't be tempted, but I think seeing your presentation and everything, I just couldn't stop myself. No, I think it's been really helpful, especially for us as well. When we see someone in ER presenting, I think you already mentioned about symptoms quite similar to BPD and psychosis and behavior elements, everything. It's really, I think we have to be very careful when we diagnose someone. It's so easy to diagnose people with a psychosis.
Don't look at me, look at the road.
Yeah, no. I think I'm in a car park now, absolutely fine. So it's so easy to people diagnosed with psychosis, actually. So I think I really appreciate your presentation. It's really, really helpful.
Thank you so much. Yeah, and to take on that, absolutely. So schizophrenia, one of the big confounder is the sensory problems and the weird way of thinking, and catatonia, right? Catatonia is very important, and the person, and when I was trained, we spoke about excited catatonia. We're seeing these people who are catatonic, and you push them and they have this explosion, which I think is what you push someone in a shutdown, they go into a meltdown. So very important. But as you said, a lot of patients have been diagnosed bipolar and bipolar 1 and come to me with mood stabilizers, no family history, no previous history, but they've been, and if they've been smoking a little of marijuana, they may have been psychotic briefly. But also the meltdown is so scary, the yelling, the violence, that and when you have only that picture in an emergency room, and then you give them antipsychotic, the next psychiatrist say, oh, psychosis. So absolutely, thank you so much, and it's very important.
And I think another
with all
point
that.
you mentioned about we don't see improvement, because that's clearly indication that's not a psychosis, that's something else we need to look into. And I have seen people are just numbers of antipsychotics believing, oh, another antipsychotic going to work. No, it's not going to work, because that's not a psychosis. I totally agree. I think very informative. Thank you for that.
A short note also for antipsychotics. So I've been used. I mean, my expertise was borderline for 30 years. So many patients would come and being misdiagnosed bipolar, for instance,
Yeah.
and with antipsychotic, we're talking more about the countertransference of the psychiatrist than really the patient. So it's rare that I give antipsychotics someone who is autistic and who doesn't have bipolar or schizophrenia. But I've
Yeah.
noticed, and some patients noticed, sometimes when the rumination and the obsession are so difficult, including rumination about suicide, a lot of patients felt helped by low dose of quetiapine. I mean, I'm not advertising. I don't like to use that as an antipsychotic when I really need an antipsychotic. But
Yeah.
sometimes for a patient, so I'm careful because of the metabolic syndrome and all that. But it may help at time. So that's to keep in mind. Yeah. Thank you so much. I'm happy
Thank
it was.
you much again. Thank you so much. Really appreciate it. Thanks. Bye.
Thank you. Thank
Bye.
you so much, Dr. Grosjean. Excellent presentation. You can see how I think when we
Yeah.
spoke on the phone, I talked about how I thought there'd be great interest in our department, and clearly there is. And I just want to echo Patricia's comment. Thank you so much for your commitment to sharing your knowledge and educating us, particularly so early in the morning. So I can't thank you enough.
Thank you so much. Well, it was a pleasure. I'm happy it was useful, and we may until we meet again.
Until we meet again. Thank you so
Exciting.
much. I hope you enjoy the rest of your day. Thank you, everyone. We'll see you next week.
Thank you. Bye-bye.
Bye.
Bye-bye.